All right, hi, welcome to Dizziness. Dizziness, really common presentation actually, but this might seem a little silly, but we're going to begin with a very important question. And once I've had a sip of tea, and that question is, what is dizziness? Now, the patient's going to present to you with three common things. They're going to say, the room is spinning, right? That's actually vertigo. They're going to say, I can't keep my balance. So the room is stationary, but they can't keep their balance. That's an equilibrium issue. That's disequilibrium, right? They might also say, I keep thinking I'm going to faint for a moment. Now that's neither vertigo or disequilibrium, that's presyncope. If syncope is your faint, then feeling faint is the prodrome, the presyncopal event. Vertigo is also called rotatory because that's the spinning one, and then non-rotatory can be branched up into the disequilibrium and presyncope. So these terms will be batted around, used interchangeably, but there are key differences between them that you should be well aware of. Okay, so we know what dizziness is now, but what causes it? Well, you can divide it centrally or peripherally. Is it the central nervous system? Is it the peripheral nervous system and other causes? And that's important, and we'll come to how to screen for that later. But an overview of the conditions combining central and peripheral together, the mnemonic I've come up with is head spin. So hypotension, of course, a transient drop of cerebral blood flow is going to cause an altered level of consciousness, right? Dizziness. Ears. Three conditions associated with the ears, which we'll get to. Alcohol, diabetes, and stroke. Those are separate presentations in and of themselves. We've said presyncope. I stands for inflammation, and this is inflammation of the labyrinth and the vestibule, so important inner ear anatomy that we need to go into. And then neoplasm of the PCF as well as neurotoxic medications. So this is the head spin. Let's make it a breadcrumb trail, and let's use this to ground where we go in the lecture. So H is for hypotension. And if you think about positional or orthostatic hypertension, in this case, blood pressure changes suddenly, it drops, due to a combo of things usually, medication, neurologic or cardiovascular disease. If your neurological systems cannot compensate for changes in cardiovascular need, then there's going to be a hypotensive event. Similarly, if the cardiovascular system can't perfuse because of heart issues or atherosclerosis of the carotid arteries, CAS or carotid artery stenosis, that'll be the case. And then medication, things that are going to slow down your heart, such as beta blockers, to treat the rate problem of atrial fibrillation. So these patients, very strict criteria of a 20 systolic or a 10 diastolic drop within 3 minutes. You need to do a sitting and standing blood pressure within that 3-minute window, and then they can be referred secondarily to things like tilt table tests, where they tilt the patient in a funny kind of way to see the changes. But normally there's a stress test done before that, and tilt tables are quite rare. You need to treat the cause. So normally it's medication, or they're not being controlled well with their cardiovascular things, or maybe they're a candidate for some sort of stenting or other kind of procedure. But it is hard. And it's hard because of how common it is, right? But here's a little fun tip for you. If you take the blood pressure within 1 minute, it's supposedly more sensitive and specific to some of the bad stuff. So NICE do say within 3 minutes, try to take it as soon as possible. That's good for consultation times as well. Now, 1 in 5 OAPs have orthostatic hypotension, and 1 in 3 OAP quote-unquote drop attacks are due to OH. This makes it a very important differential to know. Very important, epidemiologically and in terms of morbidity. So E is ears. Now there's 3 ear conditions that we need to think about. BPPV, Meniere's and Cholesteatoma. BPPV stands for benign paroxysmal positional vertigo. The path here is that the canaliths or stones within the endolymph of the inner ear end up in the semicircular canals. So they should be in what's called the otoconia, bulging from the utricle and the saccule in the middle portion, right? So they should be not in the labyrinth, but they should be in the vestibule. Revise your inner ear anatomy if you're not comfortable with this. But basically, if you have stones where they shouldn't be and they're running around the semicircular canals, and semicircular canals are important for knowing your position in space, and you've got stones rattling around in there, that's going to cause problems with your ability to know where the world is. So you're going to have a rotatory vertigo, okay? The name is fantastic, BPPV. I wish all conditions were named like this because it tells you what's happening. Okay? Paroxysmal means a sudden onset. Position, it's triggered by the canals being in a certain position, so the stone moves and then it gets triggered. And vertigo is that rotatory spin. And if the room's spinning, what do you feel? You feel sick. You need to investigate with a manoeuvre called the Dix-Hallpike manoeuvre, and then you will manage them with reassurance normally because it's self-resolving, or you can consider the Epley manoeuvre. The Dix-Hallpike manoeuvre is manoeuvring the patient's head into a position to trigger the BPPV, a horizontal nystagmus made with a little bit of torsion occurs, okay? And then you can do another manoeuvre of the head to lodge the stones the other way to help them clear and help resolve. But if the symptoms are really bad, you can give them vestibular suppressants and antiemetics. Now, Geeky Medics have a brilliant video on how the Dix-Hallpike manoeuvre and the Epley manoeuvre happens, just in 2 minutes. Have a watch of it, because GPs like to see you do it on placement. It's really simple. For copyright reasons, I'm not going to play it, but shout out to Geeky Medics for this great, nice, simple, free video. If you just Google Geeky Medics Dix-Hallpike, you will find it no issue. So what about Meniere's disease? So Meniere's disease is another problem with the inner ear. Instead of having stones in the wrong place, there's too much endolymph. Endolymph is the fluid in which those stones are running about. But in Meniere's disease, it's not the stones, it's too much endolymph. You can think of it kind of like glaucoma of the ears. Either there's too much endolymph being made, and or there's too much drainage on the other side. They're going to present with a condition called hydrops, and hydro is from the ancient Greek meaning water, okay? We'll come to that in a minute, but the hydrops is a syndrome of different things, and I've got a mnemonic for that in a moment. Audiometry is the gold standard approach for Meniere's disease because they get fluctuating hearing loss, sensory neural hearing loss. So it's very important that they're sent for audiometry. And that can be a pure tone or a speech threshold. And these basically is where you play a tone, beep, at a given decibel, and if they can hear it, you make it a bit lower and lower and lower. It's kind of like visual field static perimetry. They're looking for a threshold at which you can hear it. So they'll go quieter, 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 quieter until you can't hear it anymore. Then we'll go up one, down one, until they find that tone. And it's a pure tone, beep, but then also speech. So they'll do more of a real world example. They'll fire words at you of a certain decibel, okay? So the management of too much fluid is low salt and diuretics. Get the fluid off them, basically, and that's no exception for endolymph. And you might need to support them with vestibular suppressants and your antiemetics, like your cyclazine, for example. Now, as we said, hydra from the Greek, meaning water. There is an island in the Greek islands called Hydra. And Hydra from the ancient Greek being that 9-headed beastie that Heracles had to chop the heads off. The last one was immortal, right? But hydrops, this syndrome, when I was making this keynote a few weeks ago, I realised that kind of handedly, it spells a mnemonic that can help you remember the syndrome. So H is hearing loss, D is dizziness, R is ringing in the ear, O is on the floor because of no balance, and P is pressure, and it's oral sensation, AU. AU oral means ear, OR oral means mouth. So just make sure that you're aware of the difference there, because they sound the same, and they're right next to each other, aren't they? So that's handy. Good tea. Now let's talk cholesteatoma. So cholesteatoma, this is gunk in the middle ear. Epithelium and keratin accumulating, and it can get quite invasive, okay? So you'll see it on otoscope, but it might rupture the eardrum, and then you'll have stinky discharge, okay? There aren't glands in the external ear that can make stinky, purulent discharge, okay? They make cerumen. You're not going to get anything other than clear fluid coming out. You're not going to get much discharge at all. But if you start to get stinky discharge, you need to look in the otoscope if it's not too painful, because you've probably got a rupture, and therefore you're going to get conductive hearing loss, aren't you? So nil, but you might need to do a CT head because you're in the temporal bone there, and you do not want there to be a fistula forming through to the cranial fossae, do you? Because that's the last thing you want. These things have to be removed surgically, and you need to also manage the symptoms of pain and such. This is what they look like, and here we've got a little cone of light, so we know that this is the right ear. Here's our cholesteatoma. Accumulation of gunk. Now we can break through to halfway because one slide is A and D, alcohol and diabetes. Alcohol, dizziness, we know, cuts off your connection to your cerebellum, so you get your Danish signs. And then diabetes, we know that diabetes causes autonomic changes and it causes neuropathy. You have vascular changes, you have metabolic changes associated with diabetes that leads to problems with the vasa navarium, or the vasa navarum, which perfuse your neurons. If your neurons are not being properly perfused, they become damaged. You get a peripheral diabetic neuropathy of cranial nerve 8 and the associated nerves of the 8th nerve central pathway. So S is stroke. So a posterior circulation syndrome from that Oxford-Bamford classification is going to cause things. As we know, it causes anopsia, bilateral sensory motor signs, cerebellar signs, cranial nerve palsies. And one of the cranial nerve palsies that it can cause are things like your dizziness, your ataxias. And so that's a good differential you need to bear in mind. Does this patient acutely need a stroke workup? Really important. So P is presyncope. And if you remember this slide from 10 minutes ago, we said that presyncope is that I keep thinking that I'm going to faint for a moment. So we need to think about syncope now. So syncope is transient cerebral hypoperfusion, okay? And the presentation is that they faint acutely and transiently. So they drop to the ground and they're straight back up. Well, they might not bounce back up, but they do not have a post window whereby they are out of it. It's a rapid recovery. Now, if a patient drops in front of you, it can be quite scary, so you need a good mnemonic. And a good mnemonic for some of the top causes is collapse, cardiovascular disease, cancer, like a space-occupying lesion in the brain, overdose, very classic, low blood pressure, like your orthostatic hypotension, a space-occupying lesion, alcohol, POTS, which we're not going to go through in this lecture, but it's a sort of like a postural orthostatic tachycardic syndrome. They stand up and the heart rate goes up. Parkinson's disease. Parkinson's disease causes, as we know, all of the motor signs, your tremor, your rigidity, your bradykinesia, your micrographia, your mouse facies, and your postural instability. But it also causes mood, sleep, and constipation issues. And a lot of that is due to CNS defects affecting autonomic regulation. And one of those things it will be affecting is the autonomic regulation, the sympathetic regulation, so you cannot compensate, so you collapse. Seizure, quite classic, and an extrinsic hazard. Why do they collapse? Well, there's nothing intrinsically wrong with them, they just tripped over a shoe on the floor, right? So, investigations, bedside blood and imaging. At the bedside, you're going to do an ECG, for obvious reasons, cardiac causes, full bloods for anemia or any kind of infections that could be stressing the system, UEs and Cs for dehydration and damage to the kidney, a BM because you should always check sugars, and you can actually make the S of collapse sugar as well, the seizure, and an echo, really important if you're querying cardiac causes. The management, of course, is way too broad for this quick overview, but you do need to treat the cause of collapse. Now, seizure and syncope are two sparring rivals, and in the history of the presenting complaint, or a collateral history at least, you need to be able to differentiate them. If you're not happy with epilepsy, there is a MedGuide lecture that I did in similar format to this, where I go through the fundamentals that you need to know about epilepsy in med school, so please do check that out. Syncope has an acute onset. There is sometimes a prodrome, but remember, they recover very quickly, okay? It can be position dependent or water loss dependent, so your dehydration. Time is the only thing that really relieves it. As we said, there's sometimes a prodrome, but it can be associated with a down tone event, a hypotonic event. There's no timing of note to be aware of, and sometimes you can have an episodic history. Seizure's a different beast, so it's acute. It can have an aura, depending on where the foci, the aberrant focus of electrical activity is, so which lobe. And then there are different types, which can be remembered with the mnemonic CAT: clonic, atonic, absence tonic, or tonic clonic. If this means nothing to you, you need to watch that seizure video. If it's exacerbated. It can be exacerbated by a trigger, for example, photophobia, flashing lights, strobe lights and things, or nothing. Time relieves it, but so do rescue meds. They're going to have a loss of conscious period, and they're going to be out for a while. The recovery takes a while. That's called the post-ictal period. Timing, so timing, as we said, a trigger. Episodic history, it could be a first fit, or there could be a past medical history of this. So to understand the eye, which stands for inflammation of the labyrinth and the vestibule, we need to think about the anatomy of what is indeed inflamed. So here's our inner ear, and there's 3 bits a med student needs to know: semicircular canals, the vestibule, and the cochlea. Okay? Your semicircular canals are going to be responsible for balance, as is the vestibule. Your cochlea is responsible for hearing. Okay, that snail shell concha is responsible for the vestibule. Is responsible for hearing in that petrous temporal bone. The 3 of them within has a bony labyrinth. So the labyrinth communicates with them all, into which there is lymphatic fluid, perilymph and endolymph. Sorry, endolymph. Perilymph is around it. But that's the most important thing, okay? There's a bony labyrinth and a membranous labyrinth. Make sure you know where endolymph and perilymph is relative to the bony labyrinth and the membranous labyrinth. Important anatomy there. So vestibular neuritis, we know that it's inflammation of the vestibule, right, or the vestibular nerve. So because of that, we can say that it's inflammation of the balance bit, and sometimes it's an upper respiratory tract prodrome history. They're going to present with acute onset vertigo only. There's no hearing loss because it's specifically, the lesion is specifically for the bit to do with balance. This is a key discriminator. If there's hearing loss, it can't be vestibular neuritis. It's a clinical diagnosis that you pass apart by seeing, is there hearing loss or not? Is there acute onset vertigo? Is there an upper respiratory tract history? Could it be anything else? You can give them things like IM cyclazine to dampen down the symptoms of acute onset vertigo, but most of this is reassurance. Cyclazine, your histamine inhibitor, H1 antagonist, is on the drugs list, so know it. Labyrinthitis, this is an inflamed labyrinth, okay? So that encompasses inflamed labyrinth, right? So that encompasses both the vestibule, the cochlea, and the semicircular canals, which means that it's both. Okay, hearing loss and balance issues. Because it's more likely to be more widespread and more likely to be bacterial, the patient's more likely to have an upper respiratory tract history and more likely to be more toxic in their presentation. They look sicker. They will need a Weber and Rinian audiogram, but this is for the most part a clinical diagnosis, particularly acutely. Okay, treat the cause if bacterial, but a vestibular suppressant, antiemetic and steroids are often required. So, N. Good old N. Neurotoxic meds. So I've put a few neurotoxic meds. Don't forget Genta. Loop diuretics can do this. NSAIDs are toxic for everything. Smoking is bad for pretty much everything. And chemotherapy. Okay, and the classic one is cisplatin. Okay? Yes. So don't forget those. These are classic things that come up. These are very common names dropped in all the time into med school, so make sure that you're familiar with them. So if we're dividing them based on central and peripheral causes, we can use 5 tests according to NICE that spell hands conveniently, so I put a hand on there. So hearing loss, the alternate cover test, where you cover each eye and see if there's any change in deviation. All you need to know about that is, if I cover one eye, if the eyes look normal, and then I cover one eye and they look normal, and then I cover the other eye, and that eye deviates, that's not normal. That means that it needs the other eye for it to be able to fixate. It's drifting. That's bad, right? You know that's bad. All you need to know is that that is a red flag for a central cause, like a stroke or some space-occupying lesion. If the alternate cover test is positive, refer them. Nystagmus. Most are benign, self-resolving when you focus, horizontal with a bit of torsion. If they're anything else, if they go in different ways, if they don't resolve with fixation, if they are vertical instead of horizontal, or if they look weird in any way, refer them. Dick's Hallpike, we know that's BPPV, we know that's peripheral, and then stability. So for stability, if they can't walk because they're so unstable, it's more likely to be central. So hearing loss is a peripheral cause usually. The alternate cover test is central, you need to screen for a stroke. Nystagmus, horizontal, is more likely to be peripheral. Dick's Hallpike suggests BPPV, and stability, can't walk, is central. So we're coming to an end now, but I thought I would just make a quick summary algorithm for you. So if the patient presents with vertigo, you're going to do a history exam and screen with hands, just to make sure hearing loss and the like, just to make sure that the patient has a central or peripheral cause. If it's central, what do? Well, urgent refer, and you need to consider a stroke workup. It's hard to say it's not a stroke workup, but you're also worried about things like space-occupying lesions. So these are red flags. Central is an urgent red flag, or a 999 if you think it's a stroke. Peripheral, these are the classic triad, right? BPPV, Meniere's, vestibular, neuritis, and labyrinthitis. So if it's BPPV, Dick's Hallpike will tell you. If it's Meniere's, they'll have high drops, right? And if it's vestibular neuritis versus labyrinthitis, is there an upper respiratory tract prodrome? Do they have a history of hearing loss? So that brings us to the end of approach to the patient with dizziness. Please do check out our website, medguide.uk. It's free. I think we've got about 2,500 questions now for med school. And yeah, good to have you around.